Welcome back. I hope you all had a good lunch. This afternoon's presentations are focused on specific pressing policy issues. Again, I'd like to say the goal of this briefing is to provide you with information and context as you prepare for the coming session. As a nonpartisan office, our role is to support your policy decisions through objective analysis, with our sole focus being the continued fiscal health of our state. So first up, we're going to have Julia Rector, who will be providing an update on education funding.
Okay, let me just make sure this is working. Thanks. All right, good afternoon. It's wonderful to see you all again. My name is Julia Richter with the Joint Fiscal Office, and I am here to talk about the Education Fund, which was alluded to a bit this morning. A reminder that Catherine just spoke about, we're nonpartisan, unbiased fiscal analysis. So I want to touch on really two pieces today. First, the December 1 letter and an education fund update as we look forward to the next fiscal year 2027, and then touching on Act 73, a review and an update of work that is ongoing in the legislative off session. So if you were to take away only a few things from what I'm going to talk about today, I wanted to start with the December 1 letter is really a starting point of education finance deliberations for the coming fiscal year. It's not final. And you all will work throughout the next session to set the yields and the property tax rates at a level sufficient to fully fund the education fund. And we'll also talk about which Act 73 passed by your bodies last legislative session, which really made significant changes to Vermont's education finance system and education system writ large. Many pieces of Act 73, as you'll recall, and we'll talk about this in a bit more detail, are contingently effective on outstanding future work from the General Assembly. So starting with the December 1st letter, which really sets the stage for the ed finance discussions for fiscal year 2027, I want to think about this or frame this part of the conversation in terms of looking forward to next fiscal year, which starts in July. What is the status of the education fund? So I'm sure that you all saw the December 1st letter was published on Monday and made the headlines, which projected nearly 12% increase in the average property tax bill in fiscal year 27. And this is across all three classes of property: homestead, non-homestead, and income sensitized property taxpayers. The December 1st letter really includes two pieces. There's a mandated forecast, which is outlined in statute and is a consensus modeling process between the Joint Fiscal Office, the Department of Taxes, the Agency of Education, and it also includes policy commentary from the Commissioner. I'm only talking about the mandated forecast piece, the consensus piece between JFO and the administration. So what is it? It really helps school boards and policymakers understand the general tax implications of the budgets and also get a look into the education fund inputs for the coming fiscal year. So it provides insight, it's a consensus estimate, and it really serves as a starting point. So I think I just touched on all of this. Before talking about in more detail what the letter does and doesn't say, I want to talk about where it fits into this process. So I chose this as a starting point. I think this was included in last year's all-member briefing. We're in a continuous time cycle, right? So this is where we kind of start. One way of thinking about it is that school boards begin preparing their school district budgets in the early fall or late summer. And then they work on those budgets, and then they provide insight to the Department of Taxes and the Agency of Education in terms of what they're thinking education spending may increase by, but they don't have all of the information available to them yet. So December 1st, the commissioner publishes this letter, which is this consensus modeling exercise, and laid out in statute are all of these parameters that we all need to abide by in terms of the modeling. Then, after the December 1st letter, policy discussions start in earnest, or I guess I should say continue in earnest at both the local and state level. So at the local level, school boards are working on their budgets, putting those budgets to voters. Voters are voting on the school budgets, and eventually need to approve the school budgets at the local level. At the state level, at the same time, you all are deliberating on how to fully fund the education fund, how to fully fund those budgets that school boards are preparing and voters are voting on. And that process is generally done in what's referred to as the yield bill, which annually funds the education fund through property taxes. So at some point, the yield bill will be passed to fund all voter-approved budgets, and really setting the yields and the property taxes. And then the more administrative pieces, the Department of Taxes uses the parameters laid out in the yield bill to set tax rates, sends those out to the towns. The towns administer property taxes. Property taxpayers pay those property taxes, school districts implement their budgets, and then the process continues. So in terms of this timeline, we're sort of right in the beginning as we're thinking about the coming fiscal year. So what does the December 1st letter tell us? It provides preliminary projections for growth in education spending, education expenditures, pupil counts, grand list, and it's really based off of the best estimates at this point in time in terms of school district and education cost pressures, as well as growth in grand list and student counts or declines. And then using a whole host of projections, the December 1st letter provides an estimate for the average property tax bill increase in the coming fiscal year. And this year, that average increase is estimated to be 11.9%. I really want to put a big exclamation mark next to estimate and average. This is using our best estimates at the time being, and we know that homestead property taxes vary across the state based off of local per pupil spending. The December 1st letter also statutorily requires a range of the per weighted pupil spending of the prior fiscal year. And we saw that that range was from about 11,000 to 19,000 per weighted pupil. What the December 1st letter doesn't tell us is it doesn't tell us what's actually going to happen in the education fund. We know we're going to have updated revenues, which you heard about from Emily this morning and Tom, the final education expenditures, which will be outlined in school district budgets and determined at the state level. And we don't know what the final property tax rates or property tax bill growth will be. That will be ultimately a policy decision by you all in terms of how to fund the education fund. So yeah, so it provides preliminary projections, but ultimately those tax bills will depend on local and state decisions. I have an asterisk here because of course they also depend on federal decisions. And in terms of the education fund, as you saw in Emily's slide this morning, the vast bulk of the education appropriations are state dollars. So it'll be up to you how you decide to respond to any federal changes. So what goes into the December 1st letter? I've mentioned this, I think, a couple of times. It's extensive consensus modeling across the administration and the Joint Fiscal Office. And we use a whole host of estimates from across these departments, non-property revenues, estimates in education spending and appropriations, grand list growth, prior year policy decisions. And a little plug, JFO published a document this year that outlined some of those major inputs and assumptions that were used in this year's December 1st modeling. That was done by my colleague, Ezra Holben, who's also joining me up here. So check it out. It's also linked at the end of the slide if you're interested in the details and the nitty-gritty weeds of the December 1st letter. I'd recommend the memo. So education fund expenditures, you may recall that annually local and state decisions determine how much is coming out of the education fund. This is forecasted to increase by about 5.4% from FY26 to FY27. And education fund appropriations are forecasted to be at about $2.6 billion. Of course, we won't know these numbers until the budget bill is passed and policy decisions are made. You'll also see that by far, the largest appropriation is the education payment. That's that top line. It's a little over 80% of all education fund expenditures, and that's the sum of education spending. So you'll recall that the amount that needs to be raised in the education fund is really driven by expenditures out of the education fund. So we can think about the ed fund as having two main revenue categories: property tax revenues and non-property tax revenues. Annually, education property taxes are set in order to ensure the ed fund is fully funded after accounting for those non-property tax revenues. So when you think about that, the higher the non-property tax revenues, the less that needs to be raised in property taxes. Vice versa is also true. The lower that the non-property tax revenues are forecasted, the more that needs to be raised in property taxes. So that's why it's important to think of the whole picture of revenues for the ed fund. In FY27, the current forecast, so the July forecast that both Tom and Emily spoke about this morning, forecast that non-property tax revenues into the education fund are estimated to grow by approximately 2.6% from the prior year. So if you remember percentages, you'll recall on the couple slides ago, I was talking about appropriations or expenditures estimating to grow by a little over 5%, non-property revenues estimating to grow by a little over 2.5%. You can see that as ed fund uses continue to grow faster than the non-property tax revenue sources, that property taxes or other funds need to make up an increasingly larger share. Other funds, for example, are the $77 million in one-time that was general fund one-time that was used last year. And this visual really shows in FY19 that green bar represents how much property taxes or some other revenue stream needed to make up the difference between non-property tax revenues and uses. And that larger green bar shows is just a visual representation of how much more needs to be picked up by property taxes or some other revenue source. I do want to note none of these numbers are adjusted for inflation, so this is representing nominal dollars. So this was touched on this morning. Education fund non-property tax revenues are coming in right around forecast at about, by the close of October, a little 0.2 million under forecast. And it appears that in November, they may be coming in a little bit softer, but that remains to be seen as those numbers are finalized. This is a chart that my colleague Pat Titterton puts out each month and is included on our website. I also want to touch on the prior year buy down of property taxes. So this is that $77 million in one-time general fund that was used last year, and the 41 million in education fund surplus. So the more money that is used to lower property taxes in one year, of course, the larger the changes in the following year, right? So in some years, the General Assembly has decided to use one-time money to buy down property taxes. Last year, the 77 million, I believe, was included in the governor's recommended budget, and then was included for the purpose of setting the yields. Part of the statutory modeling parameters of the December 1st letter is that we need to apply any projected surplus in the education fund to uniformly lower average property tax bills across all three categories. This is a policy decision that you all will wrestle with in the coming year. Doesn't need to be done this way. It only needs to be done this way for the purpose of the December 1st modeling. December 1 letter forecasts an approximate surplus in 2026 of 21 million on the bottom line. While this is surplus, it's not the same size surplus in the education fund that we've had in recent prior years. And the surplus is related to reversions that have come into the education fund from the Agency of Education and other similar, more weedy pieces that I can talk about in more detail if that's helpful. So last year, I think I mentioned this, 118 million was used in one-time money to buy down property taxes. That was that 77 million from the general fund and 41 from the ed fund surplus. I want to close with why the December 1 letter matters. We've talked a lot about what it does and doesn't show. It provides a consensus estimate of where we're seeing the education fund looking like in the coming fiscal year, and really serves as a starting point for those ed fund deliberations. And it informs you all and local school boards of pressures on the education fund and property taxes for the coming fiscal year. So changing gears and thinking not just about the coming fiscal year of FY27, but thinking about future fiscal years beyond FY27. Going to talk briefly about Act 73. You'll recall this was passed last session and made significant changes to the education system. Often last year, the act was talked about in sort of three buckets, the piece of quality, governance, and finance. And so I've tried to organize some of these slides in those buckets. I do want to touch on the fact that many pieces of the act have different effective dates. Some pieces of the act are contingently effective on outstanding policy decisions, while others are not. And I've put together the following slides as a high-level review and not an exhaustive list of Act 73. Also linked at the end of the slide deck are a host of resources, the fiscal note, a great bill summary from Ledge Council, the bill page itself. So I would encourage you to look at those if you're looking for a more exhaustive review. So education quality changes in Act 73. As I mentioned, varying effective dates and contingencies. Some of these have already come into effect, and others are going to come into effect in future years. Act 73 implemented class size minimums, created the structure for the state aid for school construction. The state aid for school construction program did not include a funding stream of that program. It narrowed criteria for independent schools that may receive tuition. It changed the appointing authority for 2 State Board of Education members, and it appropriated funds to the Agency of Education for education transformation and also established 5 limited service positions. So those were some of the big education quality pieces that were included in Act 73. I'm a little more well-versed in the funding and tax changes of Act 73 as a JFO member. So contingently effective on July 1, 2028, and I say contingently effective because you'll recall there are those contingencies like school district boundaries being operational for these funding changes to come into effect. But assuming that that's the case, Act 73 creates a foundation formula that would provide a base amount per student that is adjusted annually for inflation. Students or schools with additional needs will receive additional funding. And that's the way a foundation formula works. And this foundation formula would replace our current existing funding structure. It also would allow for limited supplemental district spending at the local level. So this would be districts could put a supplemental district spending amount up to voters to approve. And if those voters approved it, then the district would be permitted to spend above the foundation amount. That amount that they would spend above the foundation amount would be raised at the local level on an equalized tax basis. Act 73 also changed general special education funding to move from a census block grant model to a weighted special education funding model, and also included a transition mechanism to phase in school funding amounts. So essentially, if a school district currently spends less per pupil than they would receive under the foundation formula, they'll be stepped into the foundation formula amount. If they spend more per pupil than they would receive under the foundation formula, they'll be stepped down to the foundation formula amount over 5 years. There were also a host of education tax changes included in Act 73 that were also contingently effective for fiscal year 29. So in theory, all of these funding and tax changes would all come into play at the same time. Act 73 replaces the property tax credit, so that's that income sensitivity component that exists in current law, with a capped homestead exemption. So the exemptions parameters would be adjusted by inflation, and the preliminary modeling showed that the exemption would lower tax bills of Vermonters with lower household incomes. Act 73 would also establish a new property, or not would, assuming that the effective date, the contingencies are met, it establishes a new property tax classification. This is referred to as the non-homestead residential, which you can think of as second homes or short-term rentals. It puts in the work of establishing the property tax classification and doesn't spell out all the details of tax policy. So there is ongoing work that I'm going to touch on in a little bit, some of which also alludes to the property tax classification. Act 73 also creates regional assessment districts for reappraisals across the state, and also implements a transition mechanism to phase in education tax changes. So this transition mechanism is very similar to that of the funding transition that we just spoke about. It would sort of step in tax rates. So districts that would see an increase in tax rates would have that increase stepped in over time, and a decrease in tax rates would also be stepped in over time. So those are some high level, or some of the high level pieces that were included in Act 73. The Act also charged entities with a lot of follow-up work. Some of this work will be available before the legislative session, and others will be continued in future years beyond the legislative session. So some of the work anticipated before the session includes graduation requirements from the recommended graduation requirements from AOE for across the state, report on special education, which AOE has already published and is linked in this presentation, as well as a 3-year strategic plan that's coming your way. Work related to district mergers, so the School District Redistricting Task Force is coming with its report, and AOE is coming with guidance for processes associated with mergers. There's work coming to you related to governance, so recommendations for cooperative ed services, as well as final findings and recommendations from the Commission on the Future of Public Education. You also have a report coming to you from JFO about early care funding systems for early care and learning. Recommendations on a school construction division within the AOE, as well as recommendations on addressing the transfer of any debt obligations. Ongoing work related to the funding formula, so proposed standards are coming your way from the State Board of Ed of how to qualify or classify schools that are small by necessity or sparse by necessity. And JFO is also under oh, this is not coming before the legislative session. We've got a report coming to you from JFO on inflationary measures to be included in the foundation formula. And lastly, AOE is coming with an implementation plan for statewide financial data and student information systems. So a lot of reading coming your way. There also will be additional follow-up work coming during the legislative session and after this legislative session from various entities. I honestly started putting together the slides outlining all of the work and realized I only had half an hour. So I cut it down to this bulleted list. Some of these areas include work on quality, governance, and finance, special education, school calendar, voting wards. JFO is in the process of issuing a contract for recommended updates to the foundation formula, required in Act 73, additional work on the homestead exemption, property tax classification, and regional assessment districts. So a lot more is being done. So in closing, I sort of talked about these two parallel education finance conversations that you all are having at the moment. One, what is happening in fiscal year 2027? The December 1st letter really kicked off that deliberation. And you will all be working throughout the session to set the yields and the property tax rates in FY27. And then two, what happens beyond FY27? There were numerous and significant changes that were made in Act 73 to Vermont's education system and ed finance system for future fiscal years. So that's all I have prepared. I'm just gonna go one further and just say again, these are some of the resources that I was referencing throughout the presentation. And I think I have time for a couple questions, if anyone has any. Yes. Oh wait, hold on, I need a, all right.
Thank you. Can you remind me what are the steps that need to happen in order for us to move to the foundation formula, or is that automatic?
So the foundation formula is contingently effective on a number of pieces. I don't want to say them all out loud right now because I'm worried I would forget something, but it's outlined in the effective dates at the end of the bill, and I can follow up with a link to the bill language itself. Yes.
So as I understand, the December 1st letter uses data that's gathered on projected budgets, even if early in the process. And you've talked about how something to keep in mind is that after receiving December 1st letter, many things can happen, including school districts and school boards adjusting budgets. Is there data that indicates that they in fact make those adjustments between receipt of December 1st letter and town meeting day?
That's a great question. I think the answer to it is similar to most ed finance answers, which is it depends. I think it depends in two ways. One is it depends on the fiscal year and the direction that school districts and school boards are hearing from the state. You'll recall a couple of years ago with the projection of 18.5% increase from the December 1st letter and the transition mechanism from Act 127, there was a lot of deliberation at both the state and local level of how school district budgets should or shouldn't be adjusted. That being said, school districts are generally, as I understand it, pretty far along in their budget deliberation process. So I think it depends on each individual school district how they will adjust their budget or not, dependent on the December 1st letter. What we do see is that the education spending projections and estimates that are included in the December 1st letter generally directionally quite accurate. The number itself varies year over year, dependent on how much information school districts have when they're submitting that estimate to the Agency of Education. So the ed spending estimate this year that went into the December 1st letter was an increase of 5.8% in education spending. Yes. I think this is my last one.
It's not actually really a question. It's that I'm trying to click on your links for the outlook and the assumptions, and both of those links go to a forbidden permission. So we can't see them. So.
Oh, okay. Well,
That's all.
thank you for the flag, and don't click them yet, but we'll get that fixed, and then you can click them.
Thank you, Julia.
Yeah.
We will fix those links, and so you can go back to that same presentation and get them from there. We'll just fix those up. Next up, we have a discussion on the state of healthcare. Nolan Langweil from the Joint Fiscal Office and Jennifer Carby from the Legislative Council will provide an overview, and then we will be hearing from several key stakeholders. So Jen and Nolan, please.
I guess we can both squeeze in here. I know this is the last presentation of the day. You guys have had a lot of information coming at you, so we'll try not to overwhelm you. We'll try to keep it entertaining and maybe scare you just a little bit. I'm Nolan Langweil with the Joint Fiscal Office.
And I'm Jen Carby with the Office of Legislative Counsel.
Welcome to the state of healthcare in Vermont. Do we have the clicker? Oh, it's right here. Beautiful. All right. Which button do I hit? The top? Oh, yeah. Thank you. Sorry about that. Let's see here. All right. So we'll kick things off with Jen and I providing kind of a high-level overview of the healthcare system to provide those of you who don't have the privilege of sitting in a healthcare committee all day. Then you'll hear from 7 different speakers who represent various areas of the healthcare system to provide you with a diverse perspective on what they see as the healthcare challenges, concerns, and opportunities in Vermont in the coming years.
And we do have a lot of great speakers and great information to get through, so we hope to have time for questions at the end, but we do ask that you hold your questions to the end. You may want to write them down so you don't forget them. Okay, we're going to start with the parts of the healthcare system. Big overview. The first group we'll talk about is the patients and consumers. That's all of us, all of your constituents, anyone who receives healthcare services. We are also looking at providers, both individual healthcare professionals and facilities and agencies that provide care. We also have payers, both public and private, and we have the regulators who are regulating aspects of the providers and the payers and our healthcare system.
This slide is meant to provide an inventory of the types of providers and how many there are in Vermont. Hospitals, of course, are the largest provider of healthcare in Vermont. They represent approximately 30% of the total healthcare spending, which was about $3.4 billion in 2022. The right side shows a breakdown by net patient revenue of hospitals across the state to kind of give you a sense of the utilization of each hospital. You'll notice that the University of Vermont Medical Center is almost half of hospital revenues in the state of Vermont. You'll also note that Dartmouth-Hitchcock is not in the chart. That's because it's not actually located in Vermont. We don't regulate it. However, it does have a significant amount of Vermont clients. Vice versa, the University of Vermont Medical Center sees a lot of out-of-state clients, particularly from northwestern Vermont. So there is quite a bit of cross-border pollination in hospital services. This slide shows you where people get their primary source of health coverage. It's worth noting that some people may be covered by multiple sources. For instance, for folks who are on the exchange and they're receiving state subsidy, they have a private health insurance product offered by Blue Cross Blue Shield of Vermont or MVP Healthcare, but they might have a relationship with Medicaid, and that Medicaid is using Medicaid dollars to subsidize their care. And vice versa, we also have dual eligibles, which are people who are both Medicare and Medicaid eligible. In those cases, those folks would show up as Medicare because Medicaid is a secondary source of coverage. You'll notice that 52% of Vermonters have private health insurance, 23% are covered by Medicare, 19 have Medicaid, 3% have coverage through military, that's TRICARE, and 3% have no coverage at all. And through the years, we've actually seen a shift of folks who move back and forth between private health insurance and Medicaid. While we've also seen Medicare slowly increase, that's because we have an aging population. And then at the same time, we've seen the uninsured rate of 3% stay roughly the same after the Affordable Care Act was passed.
So of that coverage pie chart that Nolan was just showing you of healthcare coverage and where people get their coverage, there are varying degrees to which the state can regulate or influence what that coverage looks like. And so we've broken this down for you. You can see everything that's in white is something the state cannot regulate or influence. What's in blue, we may have some or large amounts of control over. So what do we regulate or influence? The individual and small group markets, those are the markets in the Vermont Health Connect or the exchange, large group fully insured plans, and then Medicaid in collaboration with the federal government, which sets a lot of the parameters. What do we not have authority over? The state cannot regulate self-funded employer plans or self-insured plans unless they're governmental, which is an exception, but otherwise all the self-insured plans are fully federally regulated. The same is true with Medicare and military and certain other types. So you can see, even though we have a lot of people on different types of plans, the state only has regulatory authority over some of those.
In 2024, Vermonters spent estimated $10 billion in healthcare, $10 billion. This includes everything from hospital care to doctor's visits to pharmacy costs to dental, etc. 29% of that spending came from commercial insurance, while roughly a quarter of spending came from each Medicare and Medicaid. 13% came from out-of-pocket spending. This is spending that's not covered by insurance. That would include co-pays, deductibles, and costs incurred by those who don't have any health insurance. They're paying full out-of-pocket. And finally, other government was 9%. This is VA, TRICARE, and other federal employees. This is a slide that Emily showed you earlier. It's different colors, but it's the same information. From a state budget context, Medicaid accounts for about 27% of the budget. That's almost $2.5 billion of a $9.2 billion that's been appropriated for fiscal year 26. As Emily mentioned earlier, roughly 60% of those are federal matching dollars. So Medicaid appropriation is second only to K-12 spending.
Finally, before we turn it over to our panelists, we wanted to just remind you of some of the healthcare reform legislation that you passed in the 2025 session. So some of these are noted. You permanently unmerged the individual and small group markets. Those are the markets in Vermont Health Connect. You increased the monetary thresholds and made some new exclusions from the certificate of need process. You gave additional authority to the Green Mountain Care Board to be able to adjust the Blue Cross Blue Shield reimbursement rates to hospitals mid-year if necessary, and to appoint a hospital observer. You capped the hospital prices for outpatient prescription drugs, and you made a number of healthcare payment and delivery system reform initiatives, including directing the Green Mountain Care Board to establish reference-based pricing and start developing global hospital budgets. And you have the Agency of Human Services developing a strategic plan for healthcare delivery and facilitating some short-term efforts to reduce hospital spending while you're working on larger initiatives. So that's just a reminder of kind of where we were when this session ended. And with that, we will turn it over to our first presenter, who is Owen Foster, the chair of the Green Mountain Care Board.
Good afternoon, and thank you for having me. For those of you who don't know me, my name is Owen Foster, and I'm the chair of the Green Mountain Care Board and have been for the last 3 years. Healthcare is one of the most pressing issues facing the state today. It has been for a number of years, and that challenge has only crescendoed at this moment. We see healthcare in many, many of our other state challenges, including education and property taxes, our challenges with demographics and economic growth. Healthcare costs in Vermont are one of the biggest drivers of property taxes that we have. I wanted to start today by a little bit of history and some steps as to what's been done so far and where we are and what needs to happen next. In 2022, the legislature passed Act 167, a landmark bill that required the Green Mountain Care Board to study and evaluate our healthcare system. At the time of signing the bill, Governor Scott very correctly identified that stabilizing our healthcare system has become increasingly urgent, and noted that our system is currently very fragile. He also was concerned about the need to address our immediate healthcare access, financing, and affordability challenges, and stated that he could not underscore the sense of urgency that he felt. And this legislature also felt it, having passed that law. Those feelings were entirely accurate in 2022, and they remain accurate today. In 2024 and in 2025, that urgency picked up. Senator Sanders recognized it in 24, asking for immediate action from healthcare leaders. In 2025, the Agency of Human Services, the governor's office, and myself convened a set of meetings immediately calling on leaders of healthcare to help us come up with strategies to lower healthcare costs for our state. One of the major challenges we have is that Vermont's health insurance prices are the highest in the United States of America. That is wildly unacceptable. We also have declining quality and access challenges. High healthcare costs hurt people's ability to get healthcare. It is an access problem to have high healthcare costs. It hurts your downtowns, it hurts your small businesses, and it hurts your families. We must do something to address our high healthcare costs. And with some of the federal changes that are coming, that need is more urgent than ever. This graph here, you can probably surmise that the high lines are Vermont and the low lines are the rest of the country. We are an outlier and have grown far faster than the rest of the nation, including similar states like New Hampshire, Maine, Rhode Island, or other peers. I did want to acknowledge a number of steps that have been taken by the legislature, providers in Vermont, the Green Mountain Care Board, and insurance companies to address this problem. This last year, the Green Mountain Care Board approved the lowest health insurance premiums we'd seen since 2022. In fact, the benchmark plan in Vermont was the 50th lowest increase in the United States of America. We should all be very, very, very proud of having achieved that. Our benchmark plan increased 2% in Vermont. Nationally, the national average was 26%. So we bucked the curve enormously. But I want to talk about how we did it, because we can't do it again with the same tools, and more action is needed. I liken what we did to the education property tax buy down. What we essentially did was a one-year buy down, and it worked for 1 year. And so the urgency should remain with this body and everyone else working in healthcare. First, the legislature and the governor deserve credit. They took a number of bold, innovative steps to combat the urgent crisis of our healthcare affordability. One, the legislature passed a bill capping drug prices. Vermont had the highest drug prices in the country for hospital-administered drugs. We now have the lowest. It saved around $100 million and helped the Green Mountain Care Board lower the prices of the commercial insurance market. The governor and the legislature also passed bills that JFO referenced with emergency authorities and also with long-term reforms involving reference-based pricing and hospital global budgets. The Green Mountain Care Board, in my opinion, also did its part. Our staff worked incredibly hard to identify savings that would not hurt access to care. We removed in 1 year $88 million out of the University of Vermont Health Network's budget. And to their credit, they have managed that reduction without cutting services. In prior years, they had responded by cutting necessary and essential services. This year, we reduced $88 million, and they did not. And I appreciate the fact that they are managing the budget within a reasonable constraint. I also want to recognize that the Care Board put out guidance that was difficult for hospitals to achieve given their financial position. However, many Vermont hospitals met our guidance and submitted budgets with only a 3% rate increase or a 3% revenue increase. That also helped us achieve greater affordability for the state. As I said in the intro, I do want to note that our problems have not dissipated. They've just been delayed a year. And so the hard work actually starts now. I won't belabor the point, but I will mention that hospital finances in Vermont remain incredibly strained. Numerous hospitals are categorized as vulnerable or highly vulnerable in Vermont. Most Vermont hospitals have negative operating margins or days cash on hand reserves that are in a very precarious position. And our insurance company, Blue Cross Blue Shield, also remains in a very financially distressed position. How do you usually deal with this problem? A broke insurance company and a hospital system losing money. You raise commercial rates. That's not an option. The other option is you raise taxes. And I'm not seeing any hands go up to do that to solve this problem. What does that mean? We have to address the fundamental structures and fissures in our system. That was what Act 167 was all about. Addressing the hard questions and problems of regionalizing healthcare, removing waste, consolidating services, and increasing the operational efficiency of our healthcare system. The Oliver Wyman report, which was the outproduct of Act 167, deemed our system badly broken, and it was correct. Our system is badly broken, and if we want to drive lower healthcare costs, we have to address those fundamentals. We need better access to primary care, better access to long-term care, and much better access to mental health care. We have not put our money as a state where our mouths are in terms of what we prioritize in healthcare, and at this time, we need to do so. When the Green Mountain Care Board lowers rates, it is the right thing to do in the context in which we've done it. That does not mean there are not consequences. Less money means consequences. And what we have experienced are closures in service areas and reductions in services that are harmful to communities or potentially harmful to communities. Act 167 set up a planned, intentional process so that we have necessary care in each of our communities. When there's not a coordinated approach, people will close services in their own short-term financial self-interest. And then you end up with deserts of care. Lamoille County does not have birthing anymore. Inpatient pediatrics at Rutland is currently on the table as another closure. In 2024, UVM cut very sensitive services, including dialysis, inpatient psychiatry, and primary care. Those are not the services we necessarily want to cut, because while they may be good for that particular hospital's bottom line, they're not good for the system. And at this stage, we need good decisions for the system. I urge you to continue the focus on healthcare this year in this session, and I appreciate everyone's support. Thank you.
Now we're going to hear from Jill Mazza Olson, the Medicaid and Health Systems Director for the Agency of Human Services.
Great, thank you. Hi, everybody. Good afternoon. Jill Mazza Olson. I've been in my role for about 2 months. And if I look familiar to you, it's because I have lurked these hallways for 25 years on behalf of providers, and I've made a pretty big shift to take on this new challenge in this time. And I'm really excited to be here. And I'm grateful for the opportunity to serve our state in a new way. Thank you to Owen for teeing things up. Actually, I'm pleased to say pretty much as I expected. So I think he and I are very much on the same page about where we are. I do want to talk about the challenges that are particular to the work that the Agency of Human Services does and our current role in trying to meet those challenges. There we go. So as Owen said, I'm really worried about access to care. And it's not just our hospitals that are fragile. So I think this is something that's really important to understand. We have fragile home health agencies. We have fragile community mental health centers. We have fragile federally qualified health centers. There's really no I can't actually think of a part of our healthcare system that I'm not concerned about in terms of their capacity to provide services. So there's a lot of challenge there. And what that creates is gaps in care. So we have deserts forming of areas where there isn't a particular service. There's a part of our state where we don't really have home health services right now. And what that means is it actually makes it harder for hospitals to do some of the cost reductions that we need them to do. Because if they can't discharge a complex patient to a nursing home, to a home health bed, to anywhere else, those patients are going to remain in the hospital using more expensive resources. We really want people in the right place, getting the right care at the right time. That is part of how we address our cost challenges. I've been in this business for a long time, and we've been working on it for a long time. It's a never-ending process to try to rejigger the system to make sure that care is delivered where it needs to be. And when we don't have all the care that we need, people have access troubles, right? I mean, I'm sure you're noticing it for yourselves. If you've tried to get a primary care physician, if you've tried to get an appointment, there are all kinds of services that it's just hard to get right now. So that is a significant challenge that we face as a state, and it's taken a long time to get here, and I think it's going to unfortunately take some time to get back out. I want to also talk about some federal changes. Many of these you're reading about in the newspaper, and I wanted to highlight them here, but I think you know about them. The most pressing and immediate is the loss of enhanced federal subsidies for purchasing insurance on the exchange. So what's happening right now is there are subsidies, and I just want to say if you're someone who's getting care on the exchange, you should absolutely go there and consider your options. I don't want anyone to think they shouldn't go look and consider your options. You should. But there is a significant change here where enhanced subsidies that were passed, essentially COVID-era enhanced subsidies, are going away. So there are still subsidies. The original Affordable Care Act subsidies remain intact, but enhanced subsidies that have made a big difference in terms of affordability are going away on January 1st, unless Congress acts. And so far, that I think we all know that has not happened. That's what our federal shutdown was about. It has not happened. Our Medicaid team, if there are changes, are ready to implement them. And they're really working on their messaging to Vermonters to encourage them to look for their options. But this is going to be a significant impact on some Vermonters as their premiums go up. We're also going to see in the coming year some federal changes to Medicaid eligibility. So there are individuals now who are eligible for Medicaid, and they will not be eligible for Medicaid, or there will be new obligations either to redetermine eligibility, which means essentially checking their financial status, and it's going to be every 6 months instead of annually. So that's going to be a barrier for some people. And then new work requirements are coming into effect as well in January of 27. The agency is working really hard to minimize the administrative disruption for people and to automate things as much as we can. But there are going to be some impacts. We do expect there will be impact from these changes. Let's see. So I want to talk a little bit about opportunities. You've heard today about some of the various bills that have passed over the last few years that have tasked the Agency of Human Services in particular with some, I think, really important work. And one of those is regionalization. I think Owen Foster mentioned that. So regionalization is the concept that it goes back to this idea of making sure we have the right care in the right place at the right time. There are some services that we need everywhere. We need primary care everywhere. We need emergency services everywhere. There are other services that we need very little of, that organ transplants are things that happen outside of our state. Trauma care only happens in a few places, only one in Vermont. But there are other services, orthopedic surgeries, other kinds of surgeries, dialysis. We need to have them, but it might be possible to make them available more regionally. Yes, people will drive longer, but in some ways it may preserve services that could potentially otherwise go away. This is really complicated work, really complicated work. There are workforce considerations. There are recruitment considerations as we have these conversations. We still need physicians and nurses and other professionals to come to Vermont and to work in Vermont. So even as we have these conversations, we have to consider those impacts. So the Agency of Human Services is held a series of regional meetings with hospitals. We're playing a facilitation, convening, technical assistance, planning role to try to work with hospitals and their community partners to try to think about how we could regionalize services in a new way to both preserve access and also to reduce costs. So that's a pretty big piece of work that will build into the strategic plan that you passed last year that's due in 2028. So this is really critical work. It's also complicated by the fact that there's all kinds of federal rules about how much hospitals can talk to each other about who's going to do what. So there are actual federal barriers to some of the planning that might seem really self-evident that we want to do, and there are barriers that we have to work through to make sure that people can have the conversations they need to have. This is probably better as a handout than as a slide, but there are some emerging themes from those hospital meetings that happened over the summer. The need for some clinical service redesign, the need for electronic medical record interoperability. We're still talking about this. This has been a challenge for a long time. Workforce, workforce, workforce. Having the people we need to provide the care in hospitals, yes, but really across the system in all settings, workforce is a challenge. There are others, but those are some of the themes that we're hearing and we're talking about with our community partners. Also in the news, rural health transformation. So this is an opportunity that also came out of the HR1, the budget reconciliation bill that passed last year that made some big changes to healthcare. And one of the things it created was an opportunity for states to apply for funding up to $200 million a year. So there's sort of two tranches of money. There's $100 million that as far as we understand, the expectation is all states should get this that first payment, and then there's another $100 million that is based on a whole bunch of factors that the Centers for Medicare and Medicaid Services has set out, in addition to what they see in our applications. So there's sort of two buckets, and we applied for $200 million in funding annually for the next 5 years. We had 6 weeks to complete this application. So that's a really fast turnaround for something of this size. I am not going to go through all of the projects, but what you need to know is it's essentially one-time money over time. So we really had to think about the fact that we can't add to the base. So it's an opportunity to build things, to buy things, to scale up some of our pilot projects that we're doing in other places. It's an opportunity to increase our use of technology, and it's an opportunity to strengthen our workforce. So we should know by the end of this year what that looks like. And we look forward to working with our partners on those projects.
Next, we have Rebecca Hines. She's the Vice President and General Counsel of Blue Cross Blue Shield of Vermont. Just hit the little button right away.
Hello, I am Rebecca Hines. I am Vice President and General Counsel at Blue Cross Blue Shield of Vermont. I have been involved in the state healthcare policy discussion for 20 years, and this is a very, very important year. A little bit about Blue Cross. We are a local nonprofit hospital and medical service corporation. We have a unique statutory role in the state. And we see ourselves as a unique player, and we are very committed. Often we get painted as the big bad insurance company, but it's really just 300 to 400 employees working in Berlin and really trying hard. We are a part of your community, and we are very committed to helping improve this situation we've found ourselves in. But we are going to need support on a theme that we have consistently talked about, but have not always had support. These are three things that we're highlighting: the cost of care, and then two outside of Vermont things that are going to continue to pressure us that we do not want you to lose sight of. Often we focus on our local community. We are part of a much, much larger system, and we need to be aware of these other risks. So we highlighted those because we do think they're going to place pressure and could use some legislative attention. The cost of care. We all know that we have the highest premiums, but why do we have the highest premiums? Because we have the most expensive health care. Vermonters spend 19.6% of their income on health care, and that's the highest in the country. The average is 7.9. We pay too much for the services we get. We don't know why that is true, but that is certainly true. I will say every time I hear we have these health policy discussions, I always hear the same thing. Well, we need to invest in this. We need to invest in this. We'll make these investments and then the cost will be less. That is not panning out, and the amount of money that commercially insured Vermonters can put towards this to the system is tapped out. We can't ask for more money from them. We need to figure out ways to deliver the services that they need for the money that they have. Last year, you passed a bill that allows the Green Mountain Care Board to start implementing a reference-based pricing system. This would mean that prices would be a function of how much, a percentage of Medicare prices. We lowered the cost of outpatient drugs last year. We now have some opportunities in other places, and we don't want you to lose sight of these. As you can see, we have very, very, very high lab costs. Labs are generally the same in every location. Why are we paying this much depending on which site it is in? You can also see price variation and very high multiples of Medicare and radiology. These are real important challenges, and we need to bring these services costs down. However, we cannot break the system that is delivering these services by bringing these costs down. We need to understand why these costs are so high, and we need to proceed with judicious effort to make sure that we are not breaking the providers that are delivering our services. And Blue Cross Blue Shield of Vermont very much wants to be a part of that solution. We do not want to see the provider systems that serve us suffer, but we need these costs to go down. You can see here that the costs have gone up astronomically in the last few years. This chart shows you that they've increased 65% since 2021. That's crazy. We need to get ahead of this. A lot of it is pharmacy, which we have limited control over, but there are local costs that are also driving these expenses. Artificial intelligence. So we're seeing artificial intelligence in the healthcare system right now in Vermont because it's being deployed to increase the costs of the care by enhancing billing codes. So you go to the doctor, what used to be a 99211, which is a code that says how much the visit will cost, is now a 99215 because the AI has figured out how to find the evidence in the medical record. Do we want to have that? Now Blue Cross is going to have, we haven't, but we're going to be under pressure to invest in our own AI tools to fight that. Who is benefiting from this arms race of AI billing? There are a lot of opportunities where AI will help us, and some where it may bring down costs, but these are going to be expensive IT projects that will be very tricky to regulate. We warn you to keep an eye on this dynamic. Right now, it's mostly in the payment space that we're seeing the impacts, but we do believe it's coming for us in multiple ways. And then the last thing is private equity. So you've probably all heard that private equity is buying up a lot of health systems. Private equity is directly related to a lot of rural health closures. It is not a big problem in Vermont yet, but we caution you to keep an eye on that. We do think limiting private equity ownership of provider systems is a good strategy to reduce that risk. Additionally, we see private equity investing in a lot of the tools that both payers and providers use. And these tools are all revenue, all profit driven. We have to be careful of these external forces. And I think that might be it. This is what shows the private equity does drive up when it acquires systems. This is legislative testimony from last year. It drives up costs and decreases quality. And this is just the same, and that's all I have. Thank you.
Next, we have Devin Green, Senior Vice President of Policy and Strategy for the Vermont Association of Hospitals and Health Systems. A lot of words.
I know.
Right there.
Thank you. Thank you, and thanks for having me here today. Again, Devin Green from VAZ. And I'm going to go ahead and go forward. First, just an introduction to our hospital system. We have 16 hospitals here in Vermont that are members of VAZ. They're all nonprofit. We have 8 critical access hospitals, 1 academic medical center, the VA, and others. A couple of points I wanted to make here is out of all of our hospitals, there are 5 hospitals that are affiliated in systems, and then all the other hospitals are independent. So we have a large number of independent hospitals here in Vermont at this point. The other thing I wanted to point out is we have a high number of critical access hospitals. In case anyone hasn't been to their local hospital lately, we're not all Grey's Anatomy, huge hospitals doing everything all at once. Our critical access hospitals are small, 25 beds or fewer hospitals, but they are actually pretty efficient in providing access nationally. Nationally, we have the highest average number of patients per day in the country. The other piece I wanted to point out about the system is traditionally what you would see is a bunch of the smaller hospitals sending the sickest patients to the largest hospitals like UVMMC and Dartmouth. But we're really seeing a sea change there as part of this transformation process where our large hospitals are actually either providing specialty assistance so that we can keep patients in our small hospitals, or they are sending patients who were at the large hospitals back to their local hospital when they need inpatient care, but it doesn't have to be as high specialty as they previously needed. I think one of the things I'm most optimistic about all our presentations today, even though the healthcare landscape is really bleak, is that we all have the same goals of creating greater affordability in Vermont without breaking our system. So we don't want to see Blue Cross Blue Shield or our other insurers leave the state. We want to work with you to make healthcare more affordable for Vermonters. And as you saw from Chair Foster's presentation, hospitals worked really hard to do that along with the legislature and the Green Mountain Care Board. So we were able to take $215 million out of the system this past budget year. And that was in large part with what the legislature did and what the Green Mountain Care Board did. And we pledged to eliminate operating expenses by $100 million over the next 2 years. So the Oliver Wyman report said that hospitals needed to eliminate operating expenses by $300 million over 5 years. We're going to beat that amount by 2 years. And I do want to push back a little bit on the idea that that was a one-time buy down. I think those are changes that are baked into the system now. We are changing the cost curve, so it will be lower going forward. It's not as if we're going back. We had a one-time buy down and we're going back. Things are improving, and our hospitals are really committed to increasing affordability further. So you heard from Jill Olson about transformation and regionalization. Hospitals are all in on that. We're committed to doing regionalization. We expect this work to save about $40 million over 2 years. That's also in line with the Oliver Wyman report, which had $100 million saving over 5 years, so about $20 million per year in savings. I think a lot of folks look at that and why isn't that number bigger? And I think there are savings to be had by putting services in different areas, but I also think there's still a great need for services, and that plays into why this isn't greater savings. But we're here, we're willing to do it. I think it's going to be very important work. We will need to ensure that we have a strong transportation system to make sure that people get to where they need to be, and also strong community supports and community providers and services. We also have, and Jill Olson alluded to this, antitrust concerns. So under federal antitrust laws, hospitals, if they try to divide a market, even if it's competitive or it ends up with a good outcome for folks, it's illegal to do that unless there's really active state intent and state oversight. And so we are trying to work on how to address that, and that will likely come up this session. But with this federal law, there's both the chance of criminal charges and steep fines. So, and this is pretty unique work that we're doing. And so we're in a little bit of uncharted waters, and we want to make sure that we get this right. We also have concerns on the federal issues. Clearly, the Medicaid and premium subsidy and any folks losing their insurance coverage or not being able to afford their insurance coverage is hugely concerning for us, not only for their patient care, but it will create added expenses to hospitals. Additionally, we want to prepare everyone for that provider tax cut that's coming, and it will likely result in $133 million loss to the general fund, and could impact hospitals directly. So we are hoping that folks prepare for the provider tax loss and look at that a little bit further. But again, thank you so much for having me here today. I think, as I said, we all have the same goals. We're really interested in working with you this session and appreciate all of your work and time.
Next, we have Jessa Barnard. She's the Executive Director of the Vermont Medical Society.
Great, thank you. Good afternoon. Thank you all for having me here. Happy to share the perspective from my organization, and you'll hear also a little bit from others. So I am the Executive Director, as Nolan said, of the Vermont Medical Society. We are a provider membership association. We represent physicians and physician assistants, as well as medical students and trainees, about 2/3 of physicians practicing in the state. We're not representing any specific facility types, so our members work in independent practice, FQHCs, hospitals, primary care, specialty care, across the state. I am also informally wearing the hat of sharing some comments, not officially on behalf of, but regarding a provider, very informal coalition that actually Jill Olson, sitting next to me, started during COVID. So carrying her legacy forward, this group started meeting regularly. How could we respond together to the crisis we were in at the moment? But it's proven to be very effective at helping us share information, share strategies, potentially either testify together or share feedback on issues together. So again, I'm not really officially speaking on behalf of the coalition because we have no leadership structure, but I wanted to share some themes that came up. We worked really hard together to give input to the Agency of Human Services on the Rural Health Transformation Grant that you heard Jill speak about, and I think that really reflected sort of 6 buckets of what problems and challenges the healthcare providers are facing right now. Each one of these could probably be its own hour-long talk. The Healthcare Committee spends hours and hours on each of them, but I'm going to try to do it very quickly. And it's a little bit of a different perspective. While I echo everything you just heard about affordability and health insurance coverage, these are kind of a different lens on what are some on-the-ground challenges providers are facing right now. Jill literally stole my line of workforce. That rose right to the top of what the need is for across the continuum of care, including home health, nursing, hospitals, you name it. Nursing, for example, won a survey of healthcare providers, 5,394 nurses needed across the levels of nursing between 2024 and 2026. On the primary care physician side, similarly, doing some benchmarking, we will be almost 370 short by 2030 of the primary care clinicians we need to serve Vermonters. So everything, recruitment, retention, training is a huge need for workforce. Devin mentioned this a bit, but I'll echo patient transportation needs, both between facility types and also from home to get to appointments. We can't do the regionalization work. We can't get patients the care they need if they can't get there in the first place. So a huge priority for all of our organizations. Data sharing seems kind of in the weeds. It's not an exciting necessarily topic, but a huge issue. We, for example, heard over and over from our physician members this summer when we were meeting with our board about how could we improve our healthcare system. You know, why is it that when a patient gets hospitalized, the hospital still might not know that the patient just had all of that testing done in their primary care practice a week ago? Why is it that we're repeating images when somebody's transferred from one hospital to another? When we send a patient to a community service or a specialist, why does the primary care not always get the notes back? So we can do a lot, and actually the Rural Health Transformation Grant, I think, provides us huge opportunities to both improve patient care, reduce duplication, and reduce costs. Integrating sort of bi-directional, more mental health and substance use disorder services into primary care, and also integrating primary care into mental health services. We know a huge percent of primary care visits actually have a mental health component. So how do we efficiently get that care to patients where they're already seeking their care? And how do we fund that care more creatively so that a whole team can be involved in meeting patient needs? Bringing care to patients. So this involves not only the transportation piece mentioned, but things like telehealth, things like consultation services. So when you're in your primary care visit, that primary care clinician can get input from the specialist right then, and you don't have to go to another appointment. Mobile treatment, mobile clinics. And then I can't end without mentioning a focus on quality. You know, we hear over and over affordability. We know that's on people's minds, but can we really center quality in driving those decisions? Can it really be led by, if we improve quality, if we improve patient experience of care, if we improve outcomes, that will lead to savings and better care. So how can we lead with projects that have quality as the central value? So again, happy to go into more detail on any of these, and I'm sure your healthcare committee will be, but those are just some of the areas that our groups highlighted, and again, we think a lot of opportunity in the Rural Health Transformation Grant to try to start chipping away at these problems. Thank you.
Next, we have Amy Spear. She's the president of the Vermont Chamber of Commerce. Just hit that button.
Thank you. Thank you very much for having me here today. It's great to be here. My name is Amy Spear. I'm president of the Vermont Chamber of Commerce. A little bit about our organization to provide context of who we represent. We represent businesses of every size across every sector in all 14 counties of Vermont. And our work is really grounded in one simple mission: to advance the Vermont economy. So that is the lens that we bring to our remarks today. So across the state and really across all industries, we're hearing, one resounding fact, and I think everybody on the panel today emphasized this. Healthcare costs are among the most significant pressures facing Vermont employers today. These costs are directly affecting wages, hiring, workforce retention, and ultimately the affordability of life for Vermont families. This is not just a business issue. Looking at the cost realities, we have a couple of charts prepared for you. The first one here is comparing Vermont and New Hampshire. Vermont is an outlier, as you've heard today, on both cost and competitiveness. The cost of healthcare is a national conversation, but Vermont remains an outlier. Comparing Vermont to New Hampshire, we see that Vermont only has 2 carriers compared to 3 in New Hampshire. Vermont offers 13 plans, while New Hampshire offers 78 plans. And the family plan here can exceed $2,700 per month, while comparable New Hampshire plans are significantly lower. These differences are not abstract. I think we all can agree on that we've heard that today. They drive challenging payroll decisions, price adjustments, and difficult conversations with employees every renewal cycle. So when we look at small employers, these costs are just not sustainable. A 5-person business in Vermont can pay more than $8,500 per month for coverage. So you look at the chart up on the screen, that's the green is Vermont, and the blue is the New Hampshire plans. So employers are repeatedly telling us the same things. Annual double-digit increases crowd out wage growth and training. High premiums paired with high deductibles leave employees underinsured and financially strained. And some small businesses are dropping coverage entirely, making it harder to attract and retain talent. These pressures feed directly into Vermont's competitiveness challenges that we face. And a little bit more about what our business climate survey told us this year. This was conducted by the Vermont Futures Project, and it reinforces the lived experiences across all 14 counties. Nearly 3/4 of respondents rated Vermont's business climate 3 or below. More than 3/4 of Vermont's more than 3/4 of respondents said that Vermont's regulatory environment is not conducive for growth. And a majority said Vermont's tax system negatively affects investment decisions, especially when combined with escalating healthcare costs. Workforce growth is stagnant. Half saw no gains last year, and only 19% expected growth this year. And many employers told us they are one more healthcare increase away from dropping coverage, raising prices, or cutting jobs. These are real, lived, statewide experiences, not just isolated anecdotes. So I do want to take a moment, as others have, to acknowledge where the legislature has made progress. We appreciate the body's work on several important steps. Preventing small group and individual market merger, which protected small employers from higher costs. Strengthening solvency oversight, supporting stability in our insurance ecosystem, and advancing affordability benchmarks that begin to address system-wide cost pressures. These steps really matter, and employers have definitely noticed. But I think it's important for us to remain grounded that these systemic cost drivers do remain in Vermont. So even with progress, employers are still navigating a lack of competition, rising hospital spending pressures, higher administrative and regulatory costs, and limited plan design flexibility. And it's definitely not about blame. I want to make that very clear when we're talking about the problems that businesses are facing here. It's really about the structure and about the cumulative pressures that shape the small group market. The Vermont Economic Action Plan has made it clear in one of their recommendations. Vermont must understand and address the underlying cost drivers across the entire system, because there are real economic consequences for where our healthcare system is right now. Investment is slowing. More businesses plan to make no investments this year than anticipate major ones. When healthcare costs rise faster than revenue, wage increases are delayed or reduced, retirements are accelerating, small businesses struggle to recruit the workforce that Vermont needs, and Vermont families feel the squeeze the most. This is not just a business challenge. This is an affordability issue, it's a workforce issue, and it's a statewide economic resilience issue. So I want to thank everybody for your time and energy today. I know it's at the end of a long day with a lot of information, but I want to make sure that you are hearing what the Vermont employers are facing and experiencing every day. And just know that the data is clear and the indicators are telling us a very consistent story, that healthcare costs are not an isolated challenge. They influence wages, hiring, retention, and the overall affordability of doing business in Vermont. Many employers have told us, again, as I stated earlier, they're one more premium increase away from dropping coverage, raising their prices, or cutting jobs. Those are real economic impacts that our state's facing, and we're at a tipping point right now. These are the conditions that employers are navigating in their communities across our entire state. Again, the answers from the Business Climate Survey were representative of businesses of all sizes, industries, and across all 14 counties. So with that, thank you for your time and energy today and your continued service to Vermonters.
Finally, we have Mike Fisher. He is the Chief Healthcare Advocate. Oh, you don't have any.
I don't have any slides. I came without slides. Good afternoon. Yes, last but not least, Mike Fisher, Healthcare Advocate. The Healthcare Advocate's Office is an office and a position defined in state statute to be a watchdog, if you will, to be a public advocate for Vermonters. Thank you for giving me an opportunity to speak for a minute. I thought I would come and approach the urgency story in just a little bit of a different way. This being Medicare and Medicaid and Medicare and Vermont Health Connect open enrollment periods, that's what's on my mind. So I pulled together 3 stories to drive home today's healthcare affordability crisis, how our healthcare affordability crisis is landing in our communities. These stories are built on real cases that came to the Healthcare Advocate Helpline. I've anonymized them for obvious reasons. If they sound familiar to you, that's because they're fairly typical. There are indeed many examples of Vermonters who have access to very good, very affordable plans out there today. As Jill said earlier, our top line message always is that people should go see how the changes that we're all talking about affect their family. Don't take advice from somebody speaking to a fiscal brief to the legislature. Don't take advice from somebody on the radio. Check it out for yourself. Nonetheless, the stories I'm about to tell represent thousands of Vermonters. They're bad news stories. And warning, this is not uplifting. Veronica relocated to Rutland County from Brazil a few years ago to be closer to her daughter and to care for her grandchildren. She was successful in getting a green card, no small task, and now works a few hours a week doing administrative work for her daughter's small business. Veronica will be 63 in January. Recently, she was diagnosed with a chronic condition, and she's requiring more care and medications. In 2025, Veronica made only $9,000 and was able to get a low-cost Silver 94 plan through Vermont Health Connect. This made it possible for her to afford the care she needed. Due to recent changes in H.R. 1, she will no longer qualify for any financial help starting in January of 26 due to her immigration status. Health insurance that only cost her $12 a month in 2025 will now cost her $1,500 a month for similar coverage. Again, her income is $9,000, and her premiums alone for similar coverage is $18,000. Even if she steps down to a bronze plan, her premiums will still be more than her entire income. She can qualify for financial help from her local hospital, but she'll be facing $750 a month in prescription costs, even with her hospital's financial assistance. We don't have good advice for Veronica. Oscar and Willa are both self-employed in Lamoille County. Willa is an independent mental health provider, and Oscar works at the local auto shop. They earn together about $132,000, or about 410% of the federal poverty level. They have 2 children, ages 8 and 11. They're doing great, but their 11-year-old has asthma and requires a maintenance inhaler and emergency inhaler. In 2025, they were on a Vermont Health Connect family plan. They received a little over $2,000 a month in tax credits. This year, they got a notice that they are above income due to the loss of the enhanced tax credit. This family lost $25,500 in tax credits. They don't know what to do. They don't have any good options. The premium plus their expected out-of-pocket costs for a bronze plan for this family is over a quarter of their total income. They're debating going without insurance for themselves, buying a bronze plan for the kids, but that would still be very expensive, and they would have substantial out-of-pocket costs, and they'll be without coverage. These parents lie awake at night. And finally, Betty and Hal. Betty worked as a town clerk for 27 years, and Hal worked as a contractor doing carpentry in the winter and landscaping in the summer in Bennington County. They raised 3 great kids who've grown up out of the house and now have 2 grandchildren who live nearby. Betty is 71 and Hal is 73. Between them, their Social Security checks give them an income of $46,500, which is approximately 220% of the federal poverty level. That's nothing to sneeze at. That's pretty good. People live on a lot less for sure. But as Hal and Betty look forward to 26, they are understandably nervous about how they're going to make it. Their major expenses these days are their mortgage, their taxes, their groceries, and their health care. Betty is relatively healthy, but Hal now manages a chronic condition that requires expensive medications and appointments to specialists. They just learned that their Medicare Advantage Part C plan is ending, and they're nervous about how they're going to make it in 2026. They make too much money to qualify for Vermont's Medicare savings program, even with the new income limits that the legislature passed last year that go into effect January 1st. Between the cost of their Medicare Part B premiums, Part D premiums for a plan that meets their particular healthcare prescription drug needs, and their Medigap plan, they're looking at premiums of about $16,500 per year, or 35% of their fixed income. If we try and back in expected out-of-pocket costs, we think their healthcare expenses are about 40% of their income. Undoable. These 3 families thought they were doing everything right. They thought they were playing by the rules. And today, they are in shock and don't know what to do. Again, they represent thousands of Vermonters who are calling my office. Many of them, I'm sure, are calling you. All 3 of them are left with some bad choices and left with hope, with nothing but hope and prayer to make it through the year. Thank you.
Oops. There we go. We do have some time for questions, but before we start the Q&A, I just want to flag that earlier Representative Greer had a question about provider tax. I did circle back with the representative with an answer, but if anyone else was interested in the answer, you could see me afterwards, you could email me, or you can stand up and ask the question again. I just wanted to flag that. So now with that, we will open it up to any questions people might have for any of our panelists.
I'll stand up, ask a question. So as we're talking about education, the December 1st letter, I'm just actually really curious as to the calculations, projections that may have gone into the December 1st letter that are really tied to healthcare and healthcare expenses for our educators. And if anyone knew answers to that.
Julia, do you want to take that or you want me to take it? I'll let Julia take that. I should have given that.
Hi, Julia Richter again. The answer to that is that the increases in healthcare have been included in the education spending estimate by and large that was used for the increase in school budgets. So you'll recall that that education spending increase of 5.8% coming from the Agency of Education reflected the majority of school districts who got back to the agency, and that 5.8% included the increases in school budgets due to the rise in healthcare costs. That I don't know, but perhaps one of the panelists related to healthcare knows. But I can follow up with if nobody else knows, I can follow up with the Agency of Education and see if I can get an answer for you on that.
Oh, sorry, yes.
Yes, thank you. During Owen's presentation, he referred to the days of cash on hand with our hospitals. Part of that slide also included information about S&P Global Ratings vulnerability based on the days of cash on hand. Do those ratings impact their fiscal activities, or is that just a temperature check? Does it affect the cost of borrowing or things of that nature?
Yeah, really good question. And Owen Foster from the board. There's a lot of different factors that go into the strength and solvency of a hospital, days cash on hand being one of them. So the S&P and the bond rating agencies will look at a number of other factors too, like age of plant, what the margins are, all of those things. But the short answer is yes, absolutely. It can absolutely impact the borrowing costs for hospitals. Ms. Green has any.
And is that like including for the parent entities that you mentioned? A few of them have additional cash on hand from parent entities. Would that be a mitigating sort of impact for them then?
Correct. Some Vermont hospitals have parent entities with additional cash at them. For networks or that kind of structure, the rating agencies look at the overall total entity.
Yeah, Devin Green. The only thing I would add to that is that some hospitals are close to violating their bond covenants, which would have an impact on their borrowing and financials.
I think my question is for Jen. It's related to one of the early slides in the slide deck of what does the state regulate influence? And I'm curious, we have a large percentage of self-insured, and somehow I was under the impression that self-insured plans had to comply with state law.
Jen Carby from the Office of Legislative Counsel. No, self-funded non-governmental plans do not have to comply with state law. In fact, they are entirely regulated under federal law, under ERISA, the Employee Retirement Income Security Act of 1974. So we are preempted. There are specific preemption provisions that prevent the states from regulating.
Thank you.
Yeah, Devin Green again. I'm so used to being in committee and saying my name every time I speak up, so old habits die hard. But the thing I wanted to add to that is that we are very limited in how we can regulate self-insured, but you did address this last year with the reference-based pricing and putting that on what hospitals could charge as opposed to what insurance, impacting insurance companies. So you will have an impact on insurance companies through the legislation that you passed last year.
Senator Clarkson and then Rebecca, then Senator Lawrence.
Okay, at risk of asking the dumbest question of the day, and having been around when our healthcare costs were $2 billion a year and not 10, why the hell do we have the highest healthcare costs in the country? I know we have community rating. That cannot account for it. And I know we have rural hospitals. So does South Dakota. So does North Dakota. Why do we have the highest healthcare costs in the country? And what are we going to do about it?
That's the $10 billion question. Anyone want to answer that? Okay. That's what I said.
Hi, it's me again. So I think everyone has probably different answers on here, and there's no one single answer. I think we certainly have a combination of factors here in Vermont, and it does feel like we're a bit at the tip of the spear. So we're seeing this starting to ripple out nationally, but I think Vermont has a unique combination of, policy decisions like community rating. We have our aging demographic with the second highest in the nation. We're the most rural state in the nation. We just don't have the scale that other states have. And I think there really are, there are a lot of factors that are playing into this, and I think that's why this is a good opportunity. If we get this regionalization right, if we make some of these affordability changes in the right way without breaking our system, we can be a real model for the rest of the nation.
And I'll just add, I think sometimes we in health policy make things are complicated. There's a lot of factors, and it's true that there's a lot of things that contribute to this, but it, for me, significantly does boil down to a fairly simple thing. Things that cost more. Our prices are too high. Yeah.
And I'll also add, Jessa Barnard from the Medical Society, we also have a fairly, for better or worse, sort of uncompetitive healthcare market. We are, because partly probably we're a small state and rural state, and so we don't have a lot of choices within communities, and it's also been a very hard, again, Devin sort of led, it's a trend nationwide to see more and more medical practices, for example, affiliating with some other entity, whether that's hospitals, FQHCs, others, and those do tend to be more expensive sites of care, and there's complicated factors leading that. It's not just reimbursement, it's the administrative burdens in healthcare, it's the level of regulation, it's needing to adopt electronic medical records, but it's led to a lot of consolidation, and Vermont's actually been at the front of that curve for years. It's not a new trend in Vermont. We've often had more employment, for example, of our healthcare providers than other states, but it's getting even more so. So there's also just not a lot of options necessarily in each community where you could get other services.
Rebecca Heinz, Blue Cross. I think that's an excellent question, and I don't think we really know the answer. I think we have some ideas about what is driving these high prices. I agree with everything that Devin and Jessa just said, but we've sort of not focused on the price problem. We've talked about premiums. We've done tons of things to bring those premiums down. Has contributed greatly to Blue Cross's solvency challenges. I think asking some hard questions about what are the actual costs that are causing those prices to need to be so high. We can see that the smaller hospitals are really struggling to stay afloat. They need that income. What is the challenge that they have that other small hospitals in other states don't have? I do agree that it is a national problem, but we have a very acute version of it. And I think we shouldn't take our eye off of that problem. What is leading to these high costs, and what can we do about them?
Just one more thing to add to that as well is I think Vermont is kind of unique in that we are so very rural. We have all the sort of inefficiencies of being in a rural place and not having people packed in together, but we still have a lot of high costs. Not only is our healthcare very high, but in order for us to attract physicians, we have to pay those Boston rates in a place that is rural, which is, in other rural areas, you don't see that necessarily.
You want to provide an answer? Okay.
No, I just wanted just some Sorry, I thought I could be loud enough. Just a piece of institutional background which does not answer the question. It makes it harder to figure out. If you want to go back about 25 years or so, a little more, we were one of the lowest cost in the nation. But at that time, our rate of increase was growing faster than the rest of the country. And now we're at the highest. I can't explain that. I can just tell you it's not that we've always been that way.
Chris, I could add just one thing, Nolan. I can think of several hundreds of millions of dollars off the top of my head. One, the ACO didn't work. Period. It didn't work. It did not save us any commercial money. In fact, I would estimate it's probably cost over $100 million. Number two, the University of Vermont Health Network has subsidized failing New York hospitals by over $100 million. That's $200 million. Another $100 million is UVM subsidizing the lack of margin in the New York hospitals. That's $300 million. Okay, that's $300 million. Number four, we've consolidated healthcare. If you look at the time horizon the last 25 years, we've consolidated healthcare in hospitals. If you consolidate healthcare in hospitals, it's going to cost a lot more money, especially if you have some of the highest priced hospitals in the country. So you need to move care out of hospitals to other places. You need to lower the hospital prices. The problem is the hospitals don't have the finances to withstand lower prices. This goes back to what Governor Scott said when he signed Act 167 that you all passed. We need to transform the system, period.
Senator Clarkson, your question is clear as mud. Oh, sorry.
Yes, and we need to study the economic impact, Owen, as we have discussed already, the economic impact of our small hospitals on our communities, which is huge. I mean, they are such important economic drivers for our communities, and that is the additional challenge.
There are also economic drains if they cost really high prices, because I know other businesses can grow. So yes, there is an economic benefit to having hospitals in every community, but not if they have really high costs that are cannibalizing the rest of the economy in that community. So we need a way that they're sustainable.
Just one thing to add here, I think for consideration, or as people are looking at where has Vermont changed paths at some point in time, we used to allow association health plans. Those are no longer allowed in our state. They are allowed in states like New Hampshire. So I think when we're looking at comparative opportunities, perhaps looking at what are other states doing that are in our region or economically compatible to Vermont? What do they have that we don't have? And when I look at that chart, one example is the association health plans.
Representative Holcomb, you had a question.
Yeah, thank you. First of all, thank you so much for all the work on this. I really appreciate it. I know it's incredibly hard. And I also appreciate your commitment to getting regulation and regionalization right so that you don't do harm. We are all very worried about harm at the moment. I have two questions. The first is, what's the strategy for managing the market? When Copley's Birthing Center closes, people end up going to a much more expensive place to get care. So ironically, consolidation is actually increasing cost. And without some kind of market management, I don't know the way out of that. And the second question I have is, who's tracking the knock-on effects of some of the loss of subsidies in the healthcare, the marketplace? I heard anecdotally from a school district that because the rate of growth is lower in their local budgets, I heard this actually from two districts, they're starting to see an increase in family plans in school budgets as people are leaving the marketplace and trying to figure out another place to get healthcare. I'm also worried about people who just don't get health insurance and what that does to the pool and to our cost. So I wonder if you could speak to those two issues. Thank you.
So what was the first question? So you have an answer to it, okay.
Jill Olson from AHS. So on the subsidies issues, we're just not going to know until after the enrollment period is up. We are in the middle of the enrollment period, and we are continuing to encourage people to look at those, at the plans that are available to them. I can tell you it's about 6,000 Vermonters that we expect will not have access to any subsidy at all. So that's how many won't have access to any subsidies. And then other plans, the prices will be up. So it's just, I think we will know what our enrollment in the exchange looks like next year compared to how it is now, but not until after open enrollment is over. We're literally in the middle of it. In terms of, I think you asked another question about regionalization, or sort of the issue of birthing center closing. So that's part of the work that we're doing at AHS, is really trying to improve our analytic capacity to understand the impact of one decision on the rest of the system, not even necessarily cost-wise, but even utilization-wise. So if a service is closed down and there's not capacity locally, that's really important. I think it's more the regulatory authority lies with the Green Mountain Care Board more in terms of the decisions about what can and can't happen. But it's, I think, for AHS to help the hospitals consider how they can, to help have a more coordinated conversation instead of an individual conversation. That's the whole idea. Because as you said, sometimes those individual organizational decisions aren't necessarily the most planful, as they say, or the best for the system. So that is part of our transformation regionalization work.
Okay. Oh.
And just to tag on to the regionalization plan a little bit, I think, again, you did give the Green Mountain Care Board that power last year with the reference-based pricing.
I think I'll add a number of us up here have been saying for a number of years, we have a really stark dynamic playing out. The financial pressure is here. It's being applied today. And either we're going to plan for this thing and make some reasonable, good choices, given the pressures, or the market's going to do it. And the market's going to do it in a really sloppy, horrible way that's going to hurt communities. And so I know that there's a lot of work being applied to this, and the legislature's directed the agency to be working on it. But at least from my perspective, as I see it playing out right now, it's happening now. And while I wish that we could have 3 years ago been really developing a great plan, we haven't. And so it's a really good question, and it's a source of real concern for me.
So we have a question from Rep. Rebecca and then Rep. Olson, and I think we'll see how much time is left after that.
So my question's related to workforce. When Tom Cavett was speaking earlier today, he mentioned that the immigrant community or folks born outside the United States make up about 19% of the workforce nationally, and I think in healthcare it's higher. And I was reading somewhere, probably the Times, just this week, that for doctors, it's somewhere around, they make up 25% of the workforce. Jessa, maybe this question's for you. And in rural areas, it's much higher. I don't know what our statistic is for Vermont, but I'm really curious, since immigration laws have changed since we were last in session, what are your conversations like as you consider that impact on our workforce?
I can say in the physician world, there are definitely some federal complications, especially around the HB1 visas, so I have that number right, where that's sort of the skilled worker visa, you could call it. And there is conversation about whether, the Trump administration has some authority to grant exceptions to the $100,000 new charge for those visas, and whether healthcare will be an automatic exemption or not. We've been in touch with our delegation about that. Other implications for just who can come to our country in the first place. So it's certainly, I think a lot of those are more with the federal delegation and the Trump administration, but it is something that people are talking about. There is a bill, I know, in the Senate right now around different more flexible training requirements for becoming licensed as a physician in the state based on where you've done your training. And so that's something under consideration as well. I don't know if did that answer the question?
Well, I think it may be a federal policy change that we're looking for, so it's nothing we can do here in the legislature, but it's certainly going to be an impact that we feel very locally. So my concern is, how are we preparing our workforce, our staffing, and how are we planning for any potential impact that federal policy has? I realize there's nothing we can do at the state level.
Got it. Yeah, I think that's a great question. I don't know if I'm sure the hospitals have done work around this, and it is a really important part of our healthcare workforce at all, not, physician, nursing, sort of all levels of care.
Yeah, I think we are, and this all ties together, right? Because it also goes to affordability and it helps with affordability but we are trying to get folks to work at the top of their license and ensure that we're being as efficient as possible. And that may be replacing physicians that are in emergency departments with PAs. That may be doing other sort of replacement scenarios. That's also looking into AI and seeing how that can help clinically with the assistance of a provider. But we're looking at all the options, but it's all a piece of this.
I want to answer Alyssa's question from earlier. The VHI proposed a 7.3% increase this year. That is currently with DFR and expecting a final decision in January.
All right, I think we have time for one last question, and I think we are out of time.
Last person. Primary care. So I'm wondering what the panelists think about in terms of the connection between improving access to primary care, greatly improving access to primary care, and its impact both on population health and on system costs, and what policy levers you think you can think of to help achieve that goal.
Yes, thank you for the question. I think that might have been a slightly leading question, but absolutely. The Medical Society completely agrees with you. We work very closely with the pediatricians and family physicians, and I will thank the legislature for your work last session, and the Healthcare Committee is creating a new primary care steering committee that's looking at ways to strengthen our primary care system, certainly keeping care in the lower cost settings where we can prevent hospitalizations, prevent even needing long-term care if possible, keep people at home. That's, of course, a way to not only reduce costs, but improve care and really improve what patients want in their care. So we will be talking more with many of you, I'm sure, about how to strengthen primary care in the session ahead as addressing all of those issues.
Obviously, primary care is the key to a healthy system and to healthier Vermonters, but we would caution you to be thinking about the difference between independent primary care practices and hospital-owned primary care practices and the impact that those two different models have on overall costs.
I just want to add that if you look at our Rural Health Transformation Grant, that there are various proposals, actually quite a few, that build on and I would say modernize our Blueprint for Health, which has been our primary care support model for a long time in Vermont. And so we have some initiatives there that I'm hopeful will be really helpful, and I'm really hoping that that's part of what we get to implement over the next few years. So it is part of that grant.
Please join me in thanking our speakers, all of them. Thank you all for coming today. I hope you have found this useful. I hope you've learned some things. You clearly have some big challenges facing you, and we look forward to working with you in the new year. If you have questions, email Ask JFO.